Yes, good evening, colleagues, and I hope you are well. Welcome to the clinical care platform as I try
Recording in
to
progress.
record the session. It's such a great honor to always host you. And yes, it's a cold week, and I hope you have your cup of coffee and you are ready for our commitment for continuous professional development. And we are here to help you to become a better version of yourself every single day. As long as you are committed to growing every day, we will always be here for you. So, yeah, a warm welcome to everyone. Dr. Rochelle, are you able to hear me? Welcome to Clinical Care Platform.
Good evening, Lesejo. Good evening, colleagues. I hear you loud and clear.
Thank
Can you
you.
hear me?
Yes, loud and clear. All is good. All is good. I don't know. I have this. I think my lights are creating some lines there, but it's okay. So, yeah, I think let us go for it. What I'd love to do is to just share a couple of slides with you, as always. So, I hope you can hear me and you can see the slides. Today we are going to be looking at HIV prevention again, and we are focusing on the various methods. We started with oral PrEP. We discussed the long-acting cabotegravir, and now we are going to look at the DapiRing. Oh, clinical care platform. Yeah, we are so awesome. Thanks, Rochelle, for this collaboration. So yes, we are just here to improve patient care, and if you share this mission with us, do join us, become a member, support the platform. But also, if you would love to share any knowledge with health workers, do reach out, to us. Send us that email, info@clinicalcareplatform.com, and we are happy to collaborate and to work with you. Just to say that this webinar is accredited for at least 1 point. When we exceed 1 hour in this session, it will then become 2 points. To get CPDs, you have to be a member of the platform. Alternately, as well, you have to attend. So you must meet both criteria: attend adequately for at least 60 minutes, and also join us for the membership program, which you can learn about more on our website. I think our CPDs, I think yesterday I got like 5 or so notifications from the HPCSA for my CPDs. I hope you are also receiving yours. If you have any outstanding CPDs, please just drop us an email and the team will make a follow up. But the HPCSA is really trying to catch up. I also think it's because of the end of June deadline for compliance. So please don't miss it. If you are our member and you are not compliant, send us an email. We will check. If you need ethics points, we have them galore. If you need clinical points, we have them galore. You should worry not. Just to remind you as well, on the 16th of June is Youth Day, and we are celebrating this day with a style. By doing what? Bringing you the HIV Resistance Made Easy workshop. Please don't miss it with Dr. Leon. And the follow-up weekends, we have dermatitis and we also have pulmonology. But please don't miss the HIV resistance workshop. It's going to be empowering. You will learn everything about HIV, all assorted mutations, how to use the Stanford database, etc., etc. And that is the masterclass coming your way on the 16th. And yes, our coaching program, particularly for the primaries, is continuing. If you see yourself as an obstetrician, please join us. Write your part 1 exams, and it's very, very interesting. The things that are discussed there, they make me feel like I'm an undergraduate learner again, because it's basic science. So they are talking embryos and morulas. I don't know if you guys still remember those things. All right. But for tonight, let me not waste a lot of time. We are here to discuss HIV prevention, and we are so honored with this collaboration with Dr. Rochelle Adams. She's just made herself available to offer her time to empower me and you. I'm not going to waste a lot of time to introduce her. She's now known to the platform. She's our HIV clinician. She's is a researcher. She is an expert in HIV prevention, TB HIV care, and also advanced, clinical care or advanced HIV disease management. But let's just focus on learning how to keep people who are at risk of HIV to remain HIV negative. Dr. Rochelle, can I hand over to you? And just to appreciate
Yes.
you for your availability. Thank you.
Thank you, Lesego, and thank you, colleagues. Thank you for all the warm welcome. I've started sharing my slides. Please let me know if they are visible.
Awesome. Yes, they are visible.
I'm just putting it on slideshow.
Awesome. I see you are getting a lot of hearts. I usually just get thumbs ups. You are getting lots of hearts. Rochelle, can you move your slide forward once? I just want to see. I see a gray slide. I just want to make sure that it would work. Okay. Can you stop sharing and reshare again?
Okay.
Yeah.
I'm resharing now.
Okay, a few seconds. All right. Yeah, I can see your slides now, but we are seeing the presenter mode. So maybe you want to switch the displays.
I'm unable to do that at the moment. So it's fine. I can just stay off of the presenter mode for now. That's also fine. I think let me go back. Let me exit the presentation.
Yeah,
and start again.
Yes, then it should be okay. Yeah.
All right. So I am sharing.
Yeah.
I will try and do the presenter mode and see if we're failing. No, it won't be a train smash. Are we good? Can you see the full slides?
No, what you can do, let's try for the last time. Stop sharing, and then when you before you share with Zoom, put your slides on full screen first.
Okay.
Like exit your slides and then put them
Yeah.
on full screen and then try to share.
Okay.
I don't know how possible that is. Yeah.
Well, let's not waste time, Lesego. I'm just going to go back. I'm exiting my slides. It's the first time I'm having this challenge.
Yeah. Okay.
A minute. All right.
Let's see.
There we go. Can you see?
Yep, we can see your slides. Yep, we can we can see your slides. Everything is in full screen. Yeah.
Okay, wonderful. So, welcome back, colleagues. In the interest of time, I'm going to
sorry, Rochelle.
skip through. Yes.
I'm going to stress you for the last time. We have a certain, what do I call it? Square on your right lower corner. You know what you can do for me? You remember I had said because of the video, you should click on the tab that says share video. Share the audio. Can you unclick those and you'll click them later when you play the video? Yeah. That should solve the problem. Yeah. Sorry, colleagues, we will start. A few seconds.
Okay, so let me get the slides up again.
Okay, it's okay. 100%. We are good. We are good.
So I'm going to come back. And when I'm clicking share, I'm just going to unclick the share sound, right?
Yes. Thanks.
All right.
I promise not to interrupt you.
Are we good? Are we finally there?
I have confidence that we are good. Yeah.
I'm scared to go to presenter view.
Trust God. Click that and continue. You see, you are
Are
good.
you?
And we are
I'm
good.
good. Okay.
Sharp.
All right. So there's, with looking at the ring, right, and the DapiRing ring research, I'm going to take you through the research that's been done, a little bit of talk about the ring access, and then we're going to look at what's currently happening in terms of the ring. So as you are aware, colleagues, but maybe there are some colleagues who are not here, pre-exposure prophylaxis looks at using ARVs in an individual who's HIV negative to prevent HIV uh, before they are exposed. So somebody who's going to be exposed to HIV, they start taking an ARV. And the ring is, as Lesejo said, we've discussed oral formulation in TDF-FTC, we've discussed the injectable formulation in CAB. Now we are talking about the DapiRing ring. And I want to start, and it almost seems as if I'm taking you back, but just to kind of like give you a little bit of background. So there was this International Partnership for Microbicides, which was a nonprofit whose primary focus was on developing HIV prevention products for women, including gels, films, tablets, and rings. And so they, together with the Microbicides Trials Network, did a lot of the research into the ring, and then they've handed over that intellectual property to Population Council in October of 2022. So when these studies were first being implemented, they were looking at the use of ARVs for prevention. And the thinking at the time when these studies were starting, there was that ideally we want the right drug that's safe, it's effective, ideally shouldn't overlap with ART treatment, that it should get to the site of exposure in sufficient concentrations to be effective, and it should not be dependent on user adherence, ideally. And so when they were looking at the rationale for the ring research, because TDF was in trials at the time when they were looking at the ring, and there was all of these studies that had been done looking at tenofovir in an oral formulation for prevention. And so in 2010, there was the landmark South African Caprisa 004 study, which used the tenofovir gel before and after sex in women that showed a 39% reduction in risk. There was the IPRIC study, which was done in males who have sex with men, where they used oral TDF-FTC, as well as the TDF-2 study, which was in a young heterosexual population, and then the Partners PrEP study, where they were either taking a daily oral TDF or TDF-FTC in serodiscordant couples. And so we could see that there was a reduction in HIV risk, and actually TDF-FTC was actually approved by the FDA in 2012 based on the 3 trials. However, even with these on-PrEP trials, in FEM trial, in the Caprisa 004 trial was followed on with the MTN 003 trial, where they used TDF and looked at tenofovir gel. They didn't see any efficacy in women that were at high risk. And a large factor of this was likely due to the fact that adherence to products, to an oral formulation, was difficult. And so they began this partnership, looked at DapiRing. Remember, it wasn't an ART. Originally, it had been developed for use as an oral ARV. It's a non-nucleoside reverse transcriptase inhibitor. And then Janssen licensed it to that International Partnership for Microbicides in 2004. And the ring came about, which is a flexible, elastic silicone ring. It's about 56 millimeters in diameter, 7.7 millimeters thick. It's a one size for all vaginas. So it doesn't matter if you weigh 35 kilograms, you're small, or you're 100 kilograms, it's the same vagina. It contains 25 milligrams of dapivirine, and through the course of all of the safety and pharmacokinetic studies, they found that 4 milligrams of drug is released during the month of use. It does need to be in for at least 24 hours for protective effect. And once the ring is removed, there's in essence no residual protection. And so I'm going to skip over this for time's sake, right? And I'm going to go to the next slide. And so just for the sake of time. So remember, and non-nucleoside reverse transcriptase inhibitors work at the action of the reverse transcriptase enzyme, which is step 2 in the HIV replication cycle. And so this is where dapivirine works. So it's the same. If you think about NNRTIs, that's your efavirenz, that's your nevirapine, that's your etravirine. And so what this slide is demonstrating to you is the large numbers of studies that have been done with regards to dapivirine ring research. Large numbers of safety trials. So we can see several safety trials that were done, several safety and dosing trials that were done. So if you look here, especially at the IPM 015 study in 280 women in Africa, what they found was in this study, this is where they particularly noted that from the release of dapivirine and the residual values that were left with the ring, about 4 milligrams was released over the month in the vagina. This study in particular found that the ring was very comfortable, that almost 90% of women didn't even feel it during their daily activities, that they could keep it in and they preferred using it. And in this study in particular, in a lot of these studies, they would ask about partners. Can the partners feel the ring during sex, during different sex acts? And so a large majority of partners, almost 2/3 of the partners, were saying that they could not feel it. And so IPM 031 looked at IPM 031 looked at postmenopausal women. So we know that we've got women of reproductive age. They looked at the ring use in postmenopausal women, and the PK and the safety data was comparable with women in the reproductive age groups. And so the results from these studies, remember last time we spoke about the different phases, they then moved on to safety and efficacy stage 3 studies. And the 2 studies we're going to talk about is the ring study and the aspire study, and then the open label extensions, the dream and the hope study. These were the landmark studies that showed the efficacy levels related to ring use, and this was primarily in a population from 18 years of age in non-pregnant, non-lactating women. And so further study has also been done in those populations, and we'll talk about it. So just to kind of like give you a timeline of the length of time it's taken for all of these studies to happen, starting with feasibility in 2004, 2006. The Caprisa study was released in 2010, and they were busy with pharmacokinetics and safety at the time. We did not yet have a standard of care with regards to prevention. So these 2 studies started in 2012. TDF just got approved by FDA in 2012. Their open label extension started in 2016. And then they started these studies in the other populations, which we'll talk about a bit later. There was issues with FDA, but the European Medicines Agency approved it, and then the WHO recommended in 2021. So at the time that the open label extensions were started, South Africa had piloted oral PrEP within our sex worker program within South Africa. So I'm going to give you a snapshot of these 2 studies. These are, in terms of the way that they were implemented, these were double-blinded, placebo-controlled, randomized controlled trials. And the way that they were randomized was slightly different. So in the ring study, which was the IPM027, and I'll just call it the ring study from now on, and the Aspire study, which was the MTN study. So the ring study had a 2-to-1 randomization, meaning that double the amount of participants were placed to the arm that actually had the active ingredient, and one was in the placebo arm, but it's double blinded. So the people that are randomizing don't know, the participants don't know, the dispensers don't know, the researchers don't know. Whereas the Aspire study was a 1:1 randomized control trial. You can see large numbers within the study, almost 2,000 in the ring study, and just over 2,600 in the Aspire study. HIV negative women, not pregnant, not breastfeeding, not intending to either, right? And then the ring study was done in 4 sites in 2 countries, whereas the Aspire study was in a lot more sites, right? So the Aspire study was in 4 countries. You can see South Africa had the bulk. KZN, we featured very heavily, especially in the ring study. I was actually a researcher at the time in the Aspire study at my days at Caprisa when it was coming towards the end. So in these studies, the participants would insert the ring themselves because we were trying to look at self-efficacy. So we wanted to be able to have participants inserted. If they did not feel comfortable, the nurses would also assist with insertion. It was kept in for 4 weeks, replaced every 4 weeks, and the follow-up was up to 2 years, right? And then there were samples that would be taken to check the levels of the dapivirine, and the rings were also gathered also to check for levels of the dapivirine. And so these women, when we look at their baseline characteristics, are very comparable in both of these studies. So the average age is 26. You can see it's the same in both of these studies. In the ring study, 89% were single. In Aspire, less than half were married. We can see they had primary sexual partners. They were having sex at least once a week. And in a large majority of them had children. So we were finding the right patient population to see whether this would work. In these 2 studies, in Aspire, 64% of them reported that the partner was aware of their use. And so the first primary analysis is looking at HIV seroconversion. And so we can see that in the ring study, there were 77 confirmed seroconversions in the dapivirine arm, right? And when we look at the HIV, the incidence rate, right? So this is 4.1 per 100 person year. So on average, for every 100 people followed up for a year, 4.1 became HIV positive. The hazard ratio was 0.69. So it's less than 1, showing the protective effect and a 31% reduction in HIV acquisition. Aspire, there was 71 infections in the dapivirine arm, and when they looked at the protection level in the Aspire, it was 27%. So when they looked at this data, they did further studies to try and understand amongst the different age groups. So in the ring study, they analyzed and they looked at those that were less than 21 years of age. Remember, the median age was 26. The mean age, was 26, or more than 21 years. And so we can see in those under 21, a 15% effect. The confidence interval is here. We see 1 is in the confidence interval, right? So it's not statistically significant. We can see 37% in those that are over 21 years of age. And so what they did was they actually did a treatment by age interaction to try and understand whether there's a difference between the 2 groups in the effect and whether it's meaningful. And so when they looked at this age, because we can see a difference in age, the p-value there was 0.43. And because it's more than 0.05, there's no statistical significance in the results that they are seeing. So what this means is that there's no difference in how the ring worked in the older versus the young woman that explains the results that we are seeing in the difference in protection. In O2O, where they had two sites in particular that had very, very low adherence rates, and adherence rates in relation to the samples that had been collected and the rings, right? And so what they saw when they removed those two sites, the protection level improved to 37%. In Aspire, what they also found, if you can look here at the blood samples, all right, and they found that in older women, right, they noticed that there was an increase in adherence. So the older the women were, there was an increase in adherence in the ring use. And when they combined that, looking at the protective effect, what they found was overall for the study, 1/3 reduction in HIV acquisition, but in particularly in older women, combined, there were 56% fewer HIV infection among women that were older than 21 years of age. And the conclusion that the authors came to was that the ring was not protective in young women who had low adherence. But when they looked at safety data, and I haven't put the whole host like I did before when I shared the safety data last time, there wasn't a significant difference in the frequencies of AEs between the groups. And I've shared that here as well. So with the ring study, what we noticed was, you can see they did have adverse events, they did have SAEs, but none of these SAEs, which are serious adverse events, this could be hospitalization, it could be death, it could be blood abnormalities or other things, were related to product. And they had a very low pregnancy incidence rate. And the comparable between the two groups, there wasn't any clinically significant difference between whether you got a ring with placebo or whether you got a ring with the active dapivirine in it. What they noticed was that the top 3 genitourinary AEs that they had was largely bleeding. Remember, these are also clients, participants that would have been on contraception, injectable contraception, etc., and they did find genital infections. So after these studies were released, they then offered those participants that were in those studies the option to now use the ring with the active product. And so those that were in the ring study moved into DREAM. Those that were in the Aspire study moved into HOPE from 2016 to 2018. So this study was slightly different than the first one. Remember, they would come every month. Here, they came monthly, or at month 1, they had the option of getting multiple rings. And then from month 3, they were receiving 2 rings. So they had 1 inserted on site and 2 rings they went home with. And the follow-up was for at least 12 months in both of these studies. And so the open label extension, we had just under 1,000 in DREAM, almost 1,500 in HOPE. Remember, this is not a randomized controlled trial. These are clients that everybody knows that they're on product, and we are following them up prospectively. Although when they analyze them, they would analyze them based on the groups that they were randomized to in the randomized control trial. So when they analyze the data for a participant in the open label extension, they would analyze them based on where they sat, whether they were in the placebo arm, in the RCT, or whether they were in the dapivirine ring arm. You can see from the safety results from the data, right? So most of them were grade 1, which were mild, or grade 2, which were moderate. And the investigators did not believe that these were related to the AE. Product-related AEs were things and we also did see it in some of our trials, in our implementation science, was ring application pain, site pain, pelvic discomfort or pain, suprapubic pain, vulvovaginal discomfort or pain. There were some SAEs, but none of them were related to the product. And when we look at the HIV incidence rates within the ring study, we can see that the incidence rate, they had 18 HIV-1 infections, which was an incidence rate of 1.8 per 100 person years. And this was 62% lower than the simulated placebo. And in the HOPE study, the incidence rate was 2.7, and it had been expected to be 4.4. So when you look at the summary from these phase 3 and open label trials, we can see that the average protection from the trials was 35% for the ring study, 27% for Aspire. They had 80% adherence to ring use, and there were no safety concern. In the open label study, where women knew they were getting an active product, we can see a 63% efficacy rate in the DREAM study and 39% in the HOPE study. And they also did statistical modeling for these two studies, which suggested that there was a greater risk reduction of over 50% across both of the open label extensions. And so it's not what you heard the last time when I came with CAB, and it's not what you know about PrEP. And as a result of this data, the FDA did not approve it, but the European Medicines Agency did. And in July 2020 and in January 2021, WHO recommended it. South Africa's SAPRA approved it in early March 2022. It's approved as the DapiRing. It's a Schedule 4 drug. You must be 18 years and older. And so it's not yet on NEMLAC's list for our EML. So when the data had been reviewed, one of the key issues is price. And we'll talk a little bit about this at the end. And I'll show you that data that was originally shared, with price needed to come down to 52 rands per ring to be cost effective and comparable to oral PrEP options. There was also concerns about the fact that the ring, remembering the timing of these studies, that it had been compared to placebo. We've since 2012 and in 2016, we had oral PrEP available. Some of the clients on the oral open label extension were exposed to oral PrEP, but there was no head-to-head comparison around efficacy related to the two agents. We needed data to understand adolescents, and particularly those under 18 years of age. Pregnant and breastfeeding women were excluded. So in the registration, it's also not given to pregnant and breastfeeding women. And so a lot of the implementation science studies were going to look at this very thing. And so one great thing is, if we ever do get the ring, it's got a very lovely half-life. So it's can sit on our shelves at room temperature for 5 years. It's not for use in transgender women. So with a neo-vagina, you must have been born a female in order to be eligible for the ring. We've spoken about 24 hours to be effective. It has to stay in for 28 days, and once it's removed. And so in the SAPRA package insert, it's listed the 35% overall efficacy rate. That has subsequently changed, where they've accepted the modeling data that came from the OLE. It's not in the SAPRA notification, but it's what comes out in the job aids when the different products are shared together. And so what you would note from the filing and what has been shared is, as you can imagine, because it's an intravaginal ring, most of the issues related to the genitourinary tract. And those is what we saw. Side effects, serious side effects are very rare. And in the studies, and even in some of our implementation studies, most of these persist with clients don't have to discontinue because of this. So who is eligible? The first three for any HIV prevention method. I've told you about the age. You must be 18 years. Persons engaged in receptive vaginal sex only. And this is something that when we are in a multi-PrEP market, we need to understand the different types of sex that individual has. Because if we have females who are engaging in anal sex, this is not for them, as well as vaginal sex, then this will not cover them. No allergies to any components. Remember, it's a silicone component and they must be willing. Pregnant or breastfeeding or intending to become pregnant or breastfeeding, and they could not have delivered within the last 6 weeks in order for them to get it. So the wonderful thing about the ring is, besides an HIV test, there isn't anything else that we need from this individual, because it works locally within the vagina only. There is no systemic protection from this drug. But in your clients where you need to understand Hep B, Hep C, and RPR, especially if we need to understand, would oral PrEP be better for them? Is there an indication for them because of intravenous drug use, MSMs, etc.? These other blood tests would be expedient to do. And so I'm just underpinning this slide because especially what becomes really, really important when we're talking about ring with clients is this aspect related to gender-based violence. Within the studies, they looked particularly for social harms. There was a lot of discussion around declaring the ring use to partners, because if partners do find out, remember in the studies, what we know is about 2/3 of them did declare, but large majorities, over 2/3 of partners, didn't actually know. They didn't actually feel that the ring was in place. And so that's a discussion that becomes really, really important if a partner does find out, because in most positions, partners will not feel the ring, but there are sexual positions that reduce the diameter of the vagina, or shorten, reduce the vagina so that the penis might actually feel it. And particularly if you're looking at top-down positions, or you're looking at positions when the males enter from behind, penetrate from behind. The follow-up visit schedule has been aligned with oral PrEP. So if you know the oral PrEP schedule, the ring is very much the same. Everything around every visit, what you would do in an oral PrEP client would be the same thing that you would do within a ring client. In a multi-method market, at every visit, we would want to know whether they still wanted to be on that method, whether it still worked for them. We'd want to manage side effects. We'd want to understand partner-related issues, etc. And so I'm praying this video will play. Lesego, you said I must stop sharing and share sound now. Okay, so I'm just gonna end the presentation, stop sharing, and I'm gonna come back.
And then you click the share sound button. Yeah.
I'm gonna come back and share sound. So this is an instructional video that was released by Pop Council to be able to show ordinary users and healthcare providers how to use the ring. Let's hope. Can you hear?
Yes, we can hear it. You can increase the volume, but we can hear it, yes.
Is a flexible silicone ring. It contains an anti-HIV drug called dapivirine, which works by blocking HIV's ability to make copies of itself. To reduce the risk of HIV infection, a woman inserts and replaces the ring every month. Set it and forget it. Before inserting the ring into your vagina, wash your hands in clean water and dry them. Check the expiry date on the package label. Do not use if the ring is damaged or expired. Tear the package open. In a clean place, remove the ring from its package. Choose a comfortable position for you to insert the ring, such as raising one leg, squatting, or lying down. Before we show you how to insert the ring, it's important to understand your reproductive system. Your vagina is a part of your reproductive system, along with your uterus and cervix. The ring will sit at the base of your cervix. To insert the ring, squeeze it into a number 8 shape or squeeze the sides of the ring together. Using your other hand, hold open the folds of skin around your vagina. Place the tip of the ring into the opening of your vagina. Then, use your index finger to gently push the folded ring in. Push the ring into your vagina as far as you can. If the ring is uncomfortable or painful, it might not be far enough. Try pushing it in further or removing and reinserting it. If it still feels uncomfortable or painful, remove the ring and contact your clinic or doctor. After insertion, wash your hands in clean water and dry them. With the ring in place, you can go about your daily activities as usual. You do not need to remove the ring to clean it. The ring must stay inserted for a month to be effective. It should not be removed during the month. You can have sex with the ring inserted. The ring should not be removed during or after sex in order for it to do its job. It is rarely felt by either partner. There is no need to remove the ring during menstruation. It can be used with tampons. The ring can also be used with some forms of contraception, such as the female condom, oral contraception, hormonal injections, IUD, and implants. But it is not recommended for use with the diaphragm, contraceptive vaginal ring, cervical cap, or menstrual cup. At the end of the month, the ring should be removed. A new ring should be inserted right away. Before removing the ring, wash your hands in clean water and dry them. Choose a comfortable position with your legs apart. Then, hook the ring with your finger and gently pull it out. Place the used ring in the empty package of the new ring or in tissue or toilet paper. Place it in the rubbish bin out of reach of children or pets. Wash your hands with clean water and dry them. For more information, visit your nearest clinic and speak to a provider.
Okay, so that's the instructional video that's been made available for the use of the DapiRing ring, and we can always just share that video in the chat afterwards if people do want to copy it down. I think a large concern had been around, because if you look at the studies, right, so 16% of women that into the open label extension had STIs. We had over 25%
Hi, Rochelle.
in
Yes, if you can stop sharing and unclick those buttons, and then Risha, because we see those gray boxes. Yeah, thanks.
Okay, sorry.
It's a Zoom challenge.
Okay, let me try again. I'm going to unclick. I hope we are good to go. Do you see the gray still?
Sorry, yes, it's perfect. Everything is perfect. Thank you. Yeah.
Okay, right. So within the studies, especially when we were initiating the ring, we don't want to put any medications into the vagina that would have a dilutional effect on the ring, because remember that the dapivirine has been released into the vaginal epithelium. And so the indications for not inserting the ring is if you've got copious amounts of discharge that's there, if we've got ulceration, if we've got severe inflammation or any pain, we would not be inserting the ring in a client. We would also not put in things like vaginal pessaries, clotamoxazole if you have a client that has vaginal candida. So we would give oral preparations. So within the study, we gave them fluconazole if they came in with candida in subsequent visits. And what we found was, especially in subsequent visits for clients that come in with any STIs, you could manage them with the ring in. They would have additional precautions during that time, and we'd give them. The only time we would remove the ring at the follow-up visits was in issues where we saw that they had symptoms of CET, they had ulcers, they had severe friability of the cervix, the vagina was really inflamed. I did not see many allergic reactions to the silicone, but there may be people who might be allergic to silicone, and we discontinued, obviously, if we had somebody with the reactive test. In the studies, we did pelvic exams prior to the insertion of the ring, but in our implementation science studies, pelvic exams were only done if there was an indication for it in the client that you were seeing. And so a lot was looked into whether the ring insertion increased the risk of there being PID. And in the clinical trials, no increased risk was observed. And so it's also important for us to understand, that if somebody is presenting with PID, it's important for us to be looking about this, because we don't know. Remember, a lot of STIs are asymptomatic. The people we're picking up that are coming in with the discharge are about 45 to 50% of those that actually do have STIs. And so with this is a bit of repetition, but we did have a few where the ring fell out. And so sometimes women, when they were using tampons, especially, they might pull the ring out. And the guidance on what do I do if the ring comes out? Well, it depends on where it comes out and what does it fall into. If it's falling into my panty, if it's falling into my bed, I can rinse the ring and reinsert it. If it's falling on the ground, that's a completely different story. We need to have a new ring that will be inserted. So it depends on, very, very rare. This is in our instance in the study, which I did, we didn't see many of this at all. And largely it relates to the fact that as women become very comfortable with inserting this ring high up into the vagina, it's held there. The vagina holds it tight inside. And so when it's sitting high in the cervix, it doesn't really move. So if you recall, part of those safety studies and pharmacokinetic studies, they looked at women and what happened to the levels of dapivirine when women were menstruating and using the ring, and in women that used tampons. And so what they did found that the menstruation may result in a decrease in levels, as well as with the use of tampons. Remember that liquid within the vagina can have a dilutional effect. The tampon may absorb some of the dapivirine that's been released. And so it's particularly important. Women can use the ring, and in our studies, women did use the ring, but they do need to take specific additional precautions during this period, using condoms and lubricants to ensure that they are protected, because we have seen that. The ring is probably one of the easiest products to transition between, whether I'm going from oral prep to the ring, or whether I'm going from the ring to oral or the injectable, or whether I'm going from the injectable to the ring. It's one of those that, remember, once we take the ring out, there's no more residual protection. I can start the other method on the same day. I just need to identify what the lead-in dose is going to be and my eligibility for the method that I'm going to be on. So we know with oral prep, there's a 7-day lead-in dose. Within the studies, we never utilized 2 methods at the same time. So we cannot have the ring in for 7 days whilst we are in the leading dose of oral prep, as an example. With CAB is a little bit more forgiving. We've got up to about a week after we were due for that last injection, where we're very happy with the levels. It's got a very long half-life, but we would still guide our clients and tell them just to use barrier methods or abstain, just so that that period is covered when they move off of the ring. And then you would follow the follow-up visits for the new method. So anytime we switch somebody from a method that they are known on to a method that they are unknown on, we would see them again after a month. And once they are stable on the method, we would then move them into the routine visits for the method that they move to. PEP is something that's of particular importance within the ring, especially because one of the things we do understand is that the level of efficacy, if we compare it to something like the CAB, or which is also systemic, and oral PrEP, means that we really do need to understand their ring use. Because looking at their sexual exposures in particular, and whether the ring was inside you 24 hours before and 24 hours afterwards and during the sex act, that tells us the coverage for that individual. What we found in our studies, and we had a lot of sex workers that were on the ring, we're waiting for our final data. We did not have any seroconversions. Sex workers actually liked the ring as well. When CAB came along, they moved over to CAB, but when there was an option between oral PrEP and the ring, our sex workers were using the ring. And so even from the different studies that they looked at, the more those who keep the ring in saw the benefit of the protective effect. And so we need to understand, have they had a systemic exposure? Did they have anal sex? What was the exposure that they've had, in order to identify whether they need PEP when they come back. I've spoken about how we manage the side effects. You manage UTIs as you would vaginal discharge. You would need to look to decide syndromically how you're going to manage it. If there's ulcers involved, remember that means the ring needs to be removed. If it's copious discharge, we can still manage the ring. We're just using oral agents with it, and pelvic pain usually resolved with symptomatic management. We're still reporting all of the adverse events that we see because this drug has not yet moved into market. So when it does come about, seroconversion in our implementation sites, I've shown you the data and the protective effect. Largely, we can see, even in the studies, women didn't use the ring consistently. And so there may also just be breakthrough infections related to the moderate efficacy of the dapivirine ring, the fact that it's only vaginally effective. What we know about resistance from all of these studies where the ring was compared to placebo, when we looked at resistance in the placebo arm as compared to the dapivirine arm, there was no difference in the NNRTI resistance mutations. And so a lot of what we're going to see now in the era of TLD, etc., is what the data we wanted to understand. In the studies before, our studies before we were stopped, we had not yet had any seroconversions on the ring. And so these are the sites. I mentioned these sites before. You may still have them active within your district. So now we're going to look at the different studies, especially in the different populations. So the REACH study started in 2019. Remember, PrEP is now here. So and the REACH study was a randomized crossover study. And this was looking in particular at those 16 to 21 years of age. So the way that it worked was they were randomized to either get the ring or oral PrEP for 6 months. Then they would swap over and they would get the other method. So if they won the ring, they got oral. If they won oral, they got the ring for another 6 months. And then they could choose whether they wanted oral, if they had been on it, whether they wanted ring, or whether they wanted no product at all. So this was how the study was conducted. These were young people. You can see that it was completed in 4 countries: South Africa, Zim, and and Uganda. Young girls, all right. And there had been a few pregnancies amongst the ladies. This slide is really busy, but just to say that the PrEP ring side effects in the studies with the AGYW were what they had seen in those studies, the ring and aspire and the open label. They were mild to moderate. There was no difference in the reportable AEs experience, whether they were on the ring or whether they were on oral PrEP. And most of the commonly reported AEs had actually very little to do with the ring itself. When we looked at product choice, when they came to that last 6 months, of the 227 on the study, 92 participants who reached the choice period, more than 2/3 of them actually chose the ring. And so what the study showed us is that oral PrEP and the ring were very tolerable in this young population, that if they were on oral PrEP, they were more likely to choose oral PrEP when given a choice. Drug levels, though, when they looked at drug levels both for oral PrEP as well as the ring, there was partial to high adherence for both products. And so for AGYW, we're waiting. So this is the data that, remember, SAPRA is waiting for, NEMLAC's waiting for, and this data has been published. Then the other big one was pregnant and breastfeeding women. So in the ASPIRE study, MTN 020, if a woman, you couldn't join the study if you were pregnant or breastfeeding, but if you became pregnant on the ring would be stopped and you would be moved into this other study where they would follow up the moms during pregnancy and the infants for a year of life. Very busy slide. Or only to say this, that the ring was not associated with preterm birth in 86 females that had been on dapivirine ring, and there were no difference in congenital abnormalities between the arm. They enrolled 96% of all of those infants who they retained for the 12 months. And there were no differences when we compared whether they were in placebo or study around aspects related to infant weight, height, or head circumference. The specific study that they designed now to look at women that were pregnant. And the way that they did this was they enrolled in one cohort at a time. So the first group was pregnant women, 36 weeks, where they used product for 4 to 6 weeks, and then they would review that data, right? So these were women of childbearing age from 18 years of age. Based on the external safety data review, they would move to cohort 2. So they started near the end of pregnancy, and then they slowly worked themselves backwards. And the way that they worked these first 2 cohorts, so it was 2:1. So we had 2 women, right, 1:1 in the randomized cohorts. And then for the 30 to 35 weeks pregnant, they would have used product for 7 to 12 weeks. There was another safety review. And then the last cohort was from 3 months gestation up until 29 weeks. And the study has been completed now. So the last cohort, the approval was received in December 2022. So this is the data for that study population. We can see 227 screened, 150 enrolled, 101 were on the ring, the others were on oral PrEP. Remember, we're now in the era where we're not using placebo, we're looking at oral PrEP against the ring because it's now standard of care. And they had large amounts of the pregnancy outcomes available. That cohort 1 was those who started in 36 weeks. The second cohort was 30 to 35 weeks, 106 on the ring. We had 104 pregnancy outcomes. And the last cohort is outside of the conception period, right? 251 enrolled, 202 were on the ring, and 200 pregnancy outcomes. And for this MTN042B, this is where they looked and they wanted to understand for all of the abnormalities and the pregnancies, etc., that they were looking at within this patient population. They did a study of charts within those facilities to understand through a systematic review what was the background rates to compare it to. And so very high full-term delivery rates that we can see here, right? For these clients. Obviously, for cohort 1, they were already 36 weeks when they started. Cohort 2 started at 30 to 31 weeks, and we can see cohort 3 is the one that started at 12 to 29 weeks. So we can see that the frequency of stillbirths in the Truvada arm was 2%, and for the cohort as a whole, it was 0.7%, which was lower than what was actually observed here in the background patient population. So in cohort 2, right, we had 1 stillbirth, which was in the dapivirine arm, right? You can see here the 1 stillbirth in the dapivirine arm. And this was a participant who presented to the hospital at 41 weeks of gestation with ruptured membranes for 2 days, and the fetus was noted to be breached, and she had been admitted in latent labor and subsequently developed chorioamnionitis. So when they looked in particular at preterm labor or stillbirths between oral prep and the ring, there was no difference between the 2 arms. Then they looked at peripartum and antepartum complications. And this is a very busy slide, but if you were to look critically at the data between the 2 groups, whether somebody was on ring or oral prep, pregnancy complications in this population were uncommon, and they were also similar to the background that was observed in the communities. And then lastly, is looking at pregnancy outcomes and looking at, remember there was that one participant who came in with chorioamnionitis, but there's, in essence, they had been on the ring from 30 to 35 weeks, and so puerperal sepsis, however, was not observed in the MTN042B chart, a systematic review. So when they looked, remember they followed the babies up as well, and infant deaths were very rare, and they were not related to study products. The rates of congenital abnormalities that were found were similar between both the arms. There were no maternal deaths, and there were no SAEs that were related to the study product. And so there's a big push now that is going to happen to look at this data with regards to access for pregnant women for the ring when it comes available. For breastfeeding women, the Be Protected study was done where they had a 3-to-1 randomization where women either got the ring or oral prep, and they had a 12-week exposure to product. What did they want to know? Is it safe for mom? How much medication goes to the babies? And are the users liking and using the products? So one of the things that we can see is the demographics are very similar. We've got young women here that previously all had pregnancies in the past. And I'm just going to move on for time's sake. What is very clear from the data that came through from the study was that there were no SAEs or grade 3 or higher AEs that were related to study product for the mothers. So it had an excellent safety profile for both the mothers as well as the infants. When they looked at the concentrations, because they looked for dapivirine in the mother's blood, it had been detected in the blood, which helps to confirm that the rings were being used. And overall, the amounts that passed to the blood were similar to the other studies that were being used. Dapivirine was detected in very, very small amounts within the breast milk, and most babies did not have detectable dapivirine in their blood. And so it just shows that when we're looking at, this is one of the very first studies that even gives us this level of data. The drug levels that they found in these women were consistent with product use. And so the end point of the study was that it has a very favorable safety profile among breastfeeding mother-infant pairs. The drug levels in the breast milk and the infant samples were low. And so now they are looking to prepare evidence for it to be accessible for breastfeeding women when it's released. So in my last couple of slides, how am I doing for time? I've got about 3 or 4 slides here just to talk about this study, which is the IPM044. So we know there's a 1-month vaginal ring. There's also a 3-month vaginal ring. So in this study, it's a randomized phase 1 trial, and it's a crossover study. So we had healthy participants, age 18 to 45. So they either got the monthly ring, right, for 90 days, or this 100 milligram ring that stayed in for 3 months, right? So then they had a washout period. So that was 3 months. There was a washout period, and then they would cross over. So if they had been on the monthly, they would go into the 3 monthly one that stayed within the vagina for 3 months, or looked at inserting the 25 milligram rings into the vagina. And so these were young women. We can see that they were of childbearing age. A lot of them were single. And for time's sake, I would have shared all of the other data. One of the things that they noticed was that the 3 monthly ring demonstrated pharmacokinetic non-inferiority and superiority to the 1-month ring. And there was modest increases in overall drug exposure. They surmised that the 3 monthly ring should have at least, remember, it's a phase 1 study, right? So they are surmising that it should have at least equal efficacy to the 1-month ring. And the advantages would be we'd insert it in once, it would stay in for 3 months, there's less wait, there's less clinic visits, and hopefully less annual cost. And they're expected to file this with the European Medicines Agency in 2025. We're also moving to the level of multi-purpose technologies, where we've got dapivirine with levonorgestrel. So I'm getting my contraception and I'm getting my HIV prevention in a ring. And so these 2 phase 1 randomized trials are looking at safety pharmacokinetics and specifically vaginal bleeding in healthy HIV negative participants. So the design was such that this ring is meant to stay in for 3 months, right? That's the purpose eventually, for the ring to stay in for 3 months. So this was in MTN 030 and 0541. They used the ring. It has 200 milligrams of dapivirine, and it has 320 milligrams of levonorgestrel, and they compared it to an arm that just had a 2 milligram dapivirine ring in for 14 days. This was completed in 24 individuals between May and August 2017. And then they had another group where they kept it in for a month. They had a washout period for 2 days, and then they would repeat the cycle 2 times between July 2018 and May 2019. And so what they found was that this dapivirine levonorgestrel ring was well tolerated. They observed the dapivirine concentrations in plasma continuously exceeded concentrations that was observed in the previous ring efficacy studies. The levonorgestrel concentrations in the plasma was comparable with other levonorgestrel concentrations. And so this is something that we're watching that space. Oh, I'm sorry, it's just covering over. So the Clinton Health Access Initiative working to be able to provide access to the ring, right? And so the countries that are in green, through the Global Fund support, not Clinton Health Access, it's Global Fund. So the countries in green have already placed orders for Global Fund support. We've got countries with planned orders for Global Fund support. So those that are in yellow, my deepest apologies, right? Because in 7 African countries, the ring has already been registered. So all of the catalyst countries where the ring has been registered, Eswatini, the ring has been registered. And one of the key issues is going to be to bring the cost of the ring down, because that's its biggest draw point. The 1 month ring, these are the costs where it's manufactured in Sweden. They're hoping that in South Africa, we might be able to have access to it so that we could bring the cost down, but we don't know what their cost is going to be. Remember, when NEMLAC looked at the data, they were looking at data to see how costly is it going to be for us to bring the ring in, looking at the efficacy that the ring has. So if we were looking at 29% efficacy or 62%. So when it was said to come to market, it was at $14.59, which is about 260 rands right now. And so what they reported was that the cost per year, because somebody would need 12 rings, is too high when we're looking at their cost. So at 29% effectiveness, it needed to be down to 52 rand. At 62% effectiveness, it would be about 107 rand. So cost and local manufacture is certainly going to be a big issue with the ring. So my take-home messages: the ring is here. It's registered for use in South Africa, but it's not yet available. You have to be 18 years and older, born a female, having receptive vaginal sex only. 4 milligrams of dapivirine is released over a month. It's a one-size-fits-all. It takes 24 hours to be effective, and it only works in the vagina. Once you remove it, you no longer have any protection. We now say efficacy is at 50% based on the modeling from the open label studies. We can't use it at the moment in pregnant women, breastfeeding women. If you have the NuvaRing, the diaphragm, a cervical cap, or the menstrual cup, we can use it safely with all of our condoms and contraception. We would need to use additional precautions during menstruation and tampon use, but the shelf life is really good, and we've got other studies that are on the way. Thank you. Thanks, Lesego.
Awesome, colleagues. I don't know. I am so empowered. Thank you, Rochelle. Look at all the hearts you are getting. I only get thumbs ups. So.
Thank you, colleague. No, that's not true, Lesego. I'm on your trainings. That's not true. I've attended almost all your trainings.
No, that is awesome. So I think, colleagues, as usual, this is our coaching season for the diplomas and other programs. Please note already that we have a hard stop at 8. So we're going to have a marathon through a number of questions. The first one, Rochelle, if I can maybe try and increase the font a bit. Yes, the first one is from Ntogozo. Ntogozo saying, what are the risks of inserting the ring 6 weeks after delivery? Yeah.
So remember, just from routine postnatal care, women that are post-delivery, especially normal vaginal deliveries, there's been a lot of trauma within that vagina. And so we want the vaginal epithelium to heal. Women should not also even be engaging in sex within that first 6 weeks after delivery. Introducing a new substance into that space is something that ethically we wouldn't be able to do, because we should not be introducing any new substance into a healing vagina.
Awesome. And can you insert it with an IUCD at the same time? Can the patient have both?
Yes, you can have an IUCD, and so it's compatible with all of our current contraceptive methods, except the NuvaRing, right? So that's a contraceptive that sits within the
Already.
vagina.
Yeah. Awesome.
Yeah.
Awesome.
And cervical cups, the menstrual cups. I learned about all of these things working with sex workers.
Yeah.
And
so if a woman is using the ring, but they complain of dryness, can they use lubricants? Will lubricants be considered something that can dilute the drug?
so when they did the safety and feasibility studies, they looked at its use with condoms and lubricants. And so the usual KY jelly did not seem to be an issue.
Okay, awesome, awesome. Abdullah, he says there are some points highlighted in your first 5 slides. I didn't. Could you? Oh no, I think that's because I was just running through. Sorry about that. It's already passed. So if a client develops an STI or a pelvic inflammatory disease after the ring insertion, should the ring be removed and be reinserted again after maybe they've taken the treatment?
Correct. So we would remove the ring, right? So we ulceration, CET, copious discharge. We want to treat that infection, make sure that it's been managed. Once they've healed, we then can reinsert the ring. And unfortunately, we have other options right now. So we've got oral prep that they can still take. Most of our clients would likely not be sexually active, but if they wanted to be on an alternative prep method, they could go on to oral prep.
Awesome. Awesome. Thanks for that. This is my question to you, Rochelle. So you said if we insert it, it can become effective within 24 hours. So if my boyfriend is coming over the weekend, can I insert it on Thursday and then maybe on Monday I remove it, and then when he comes back I insert another one? Yeah.
Mr. Mawela. So if you think about your tea, right?
Yeah.
And you think about how these products have been intended to use, what we are trying to reduce is user dependency.
Yes.
What we want for women, the design of this was to be able to give HIV prevention into the hands of a female.
Yeah.
The ring works best, and the data is very clear when it stays in the vagina.
Okay.
Because you have consistent release into that vaginal epithelium. In the studies, women were doing that. So that's what women were doing.
Yeah.
And that's why we saw such low efficacy.
Yeah.
In women where the vagina stayed in, we saw with the vagina stayed, where we saw the ring staying in,
yes.
That's where we saw better efficacy.
Awesome.
But we understand, we tell our oral prep clients, take it a certain way, and they might take it a different way.
Yeah, so Selby has written...
But because of its moderate efficacy, I would not be advocating for that.
Okay.
That the ring is designed to stay in. And, you know, speaking to a lot of our participants that used it for a long time, you don't feel it.
But I can
in fact,
tell you,
we make them jump up and down after they put it in, and they don't feel it.
I can tell
you can go about your daily life and forget about it there until your timer goes off on your watch to say you need to put another one in now. It's 28 days. So in South Africa we use 28 days, but elsewhere they use 30 days.
You know what I tell my patients? I tell them, tell your boyfriend only if you think he needs to know. Because as soon as he knows, he's going to say he feels something. But let's move on this one. Because with IUCDs, the same story. Even with this, is the guy's like, once he knows, he's going to say, I feel something. But anyway, let's move on. Don't respond to that one. It was just by addition. So Selby is asking a long question, but to cut it short, unfortunately, we don't use NNRTIs anymore, but the use of the DapiRing, if someone becomes positive for whatever reason on it, do they develop significant mutations against NNRTIs?
Yes, they do get mutations against NNRTIs, but then a large proportion, what they found in the studies of when they looked at the NNRTI resistance was it was comparable with placebo. And the mutations that we're getting were the same as if her clients were on placebo. And I think, remember the first slide that we looked at when we're looking at ARVs and resistance? Because ideally, if we were in a perfect world, we'd have a prevention method that was not being used in treatment. But we don't have that. CAB is used with rilpivirine in treatment, and a Capivair that's coming on board is also being studied in treatment experienced individuals. And so these are the things that why when somebody seroconverts on these products, we want resistance testing to understand how they're working. And within the studies, they want to follow these clients up after they have seroconverted to see whether now we're on TLD. And so we quite happy with somebody that's seroconverting on dapivirine. In other countries, in South Africa, if you had signs and symptoms of acute HIV, without a confirmed HIV positive result. So if I'm HIV negative, I don't require PEP, but I might have acute HIV. They were providing the ring in other countries because in terms of risk of resistance and being able to go into a first-line regimen, there wasn't much. In South Africa, we were not allowing that, and we do not allow anybody that had possible signs of acute HIV to go on any PrEP method, but other countries were allowing the ring.
Awesome. Anonymous is asking, can we insert it with a speculum considering that the cervix can look, I don't know, the direction could be up, down, left, right? And have you found that maybe sometimes the ring gets loose because it was not inserted correctly?
In fact, the experience within the studies, and remember, even in the studies with young girls, it's very easy to insert. And in our studies that I did on my project with the community outreach project, and nurses were using the ring for the first time and they were inserting it. It's very easy to insert. It's not difficult to insert at all, whether it's a nurse that's going to be introducing it, because we used to buy manuals, right?
Okay.
We used to buy manual exams, and clients themselves, remember, they're either going to squat down or they'll lie down. They'll find the position that's comfortable for them. They'll decide whether the figure 8 is better for them or whether squeezing it together is better for them to get it up as high. If they can feel it, it's not in the right place.
Okay.
And so they would need to go make sure that they've pushed it further in until they cannot feel it at all.
Awesome.
Those speculums are not needed.
No, yeah, it's too much an effort. Yeah. So Paul says, does the ring affect fertility? But as far as I know, we don't use it in pregnancy, right? Yeah.
So at the moment, it's not being used in pregnancy. And what they found, if you remember the slides that I shared, that when they looked at the placebo arm and they looked at the active arm, it didn't seem to affect fertility rates.
Okay.
Recording in progress.
The liver and the B protect.
Okay.
We don't have evidence for its use within the first trimester of pregnancy. So remember, for example, if I was on an open label extension, I was still not allowed to come into the study pregnant or on the ring or Aspire. But I might become pregnant and not know it and be diagnosed with pregnancy at my study visit. When we became aware of pregnancy, we would then remove the ring. And so those clients would have had ring within the first trimester. And so that's why the data that we got out of the Embrace study and this is showing us that it was very small numbers of pregnancies, because these studies were relatively small, the numbers that were falling pregnant, and there wasn't any safety signals that we had to worry about.
Yeah, regarding the 3 months versus the 1 month ring, were there any differences in terms of side effects, maybe prolonged exposure? I don't know. That's the question. Yeah.
So those studies were primarily because remember, if you recall, I told you one of the primary issues was about vaginal bleeding that they were looking at when they were looking at the 3-month ring. Considering now that we've got a contraceptive and we've got the dapivirine in there, and if you recall, in the early randomized controlled trials with dapivirine, women that were on contraceptives also had a lot of bleeding. The safety data was nothing to write home about in comparison to the dapivirine ring only. So if I was on the 3-monthly, so remember with this, the 3-monthly ring with the IPM 054, where they were looking at the two together, and there wasn't any real significance that they could find between those two arms. That's why they're moving forward now to look and see, can they move that 3-month ring forward?
Awesome. What if I had a partial hysterectomy? Can I still use the ring?
I don't know the answer to that question. And because we never had women within our studies who had partial hysterectomies. And so I think I would have to go and look that one up because we're not sure how it would sit knowing that the cervix is no longer there. In our studies, we didn't have it. I cannot think of a feasible contraindication to it actually being in there. But I can go and ask our colleagues to find out about that.
Awesome. And does menstruation affect the effectiveness of the
Yes, it does.
Okay.
Yes, it does. It has a dilutional effect, which is why condoms do need to be utilized, as well as if women are using tampons.
Awesome. Let me just scroll through. But in the meantime, maybe respond to my small quick question. I mean, how important is the issue of to have choice, choice? And I don't know if there's any study where they did the group, I don't know, focus discussions and getting feedback from women. And I don't know. Yeah.
I think we saw what choice did in the era of contraception, right? So we saw where we are not saying to a young person, you need to use an injectable or you need to use an implant. What we are finding is that if we allow women the opportunity to use what they can safely use, because I think we prescribe oral prep. Oral prep is highly user dependent. And that is why a lot of the research is now looking to see what can we use, what can we provide for women who are at high risk of HIV that they will be able to use. Because you need to be able to use a prevention method in order for it to be effective. For some women, the ring is that method for them. And we saw in the REACH study where a large proportion actually would want to continue on the ring. They chose the ring when previously they were randomized to either get the ring or oral prep. When they came to the last 6 months, among the 16 to 21-year-olds, they chose the ring. We found that in the first part of our study as Catalyst, when it was just oral and the ring before CAB was available, I think the issue is going to be a woman's ability to live with something, to know that there is something within the vagina.
Still in class. We'll catch up.
Thank you.
Yeah.
Very important. Choice is very important.
Yes. Is the ring reusable? Anonymous is asking.
No. So the reusable in the sense that, let's say I put a tampon in and it falls into my panty, I can rinse it and reinsert it, right? That, yes. But I can't reuse a ring beyond. We had some participants that might have kept it in for 35 days, but after 30 days, the residual volumes, we don't know how much dapivirine is actually there. So once you've had it in for the allotted time, it must be removed and a new one reinserted.
There's a question here from Suma, yeah? Yes.
And
Yeah, let's
Yes.
take the last question because this one I must ask you. Sumaya says, has the doctor herself inserted the ring? Have you? They're asking if you have tried the ring.
I've not inserted the ring. And the only reason I didn't insert the ring was because we didn't have one.
Yeah.
So they gave us dummy rings, right? But I never ever because it was study products and we weren't allowed to be on the study, I've never inserted the ring.
Okay. Okay. I don't know how.
It myself.
No. Awesome.
Yeah.
Awesome. Thanks for that. Colleagues, it's 8 o'clock. Unfortunately, we have come to the end of this session. Maybe let me ask you for your closing remarks, Rochelle, but just to appreciate you for your time, the effort. I saw many comments about the fact that it was very detailed, very informative and empowering. Beyond just saying this is the ring, now we understand the issues and the dynamics. And I mean, you might get questions from patients, you might get questions from colleagues, but your presentation was such that we are able to engage with the topic meaningfully. So just want to appreciate you for that. Your closing remarks. Thank you.
My closing remarks are, I think that in the coming 2 to 3 years, we will be entering a multi-method market. I think that as healthcare professionals, as we've learned how to discuss choice amongst contraception, discussing choice and understanding the ring and its role amongst our clients who might find this their method of choice is going to be important. And hopefully in a few years, we'd see it resolutely being made available to pregnant and breastfeeding women as well. At the moment, we're still waiting to get the price down and see if we'll be able to get it in country, in our facilities.
I'm muted. Awesome. Thank you.
you.
Thank you very much, Dr. Rochelle. Colleagues, thank you very much for joining us this evening. That's it for tonight. And if we have not responded to your question, apologies. Till we meet again on Thursday. Remember to join membership so that we can bring you more and more of these programs. And lastly, we have the Resistance Masterclass on Monday the 16th. We are young people, we are youthful, and we are going to spend the day learning. Night, everyone. Bye.